Right, good morning everybody. Welcome to this meeting of the sorry, something just came on my screen, I don't understand. Well, welcome to this meeting in public of the board of the Worcestershire Acute Hospitals NHS Trust. We've got a full agenda, a very ambitious agenda here to get through today, so everyone's attention would be appreciated. I've got some apologies. First of all, I've got apologies from Robert Toole and Joe Newton, and Lisa Peaty is attending on behalf of Joe. Is she here? I can't see her, but I'm sure she'll. Yes? No? She's.
I'm here, David.
Oh, you are Lisa. Well, yes. Welcome, Lisa. Also, welcome to Robert Mackey, who's our interim finance director. Robert Toole, as many will know, is off ill at the moment, but he's coming back in later on in this year. But Rob's stepped into the breach to help us through this process. So thanks very much for doing that, Rob, and welcome. Rob is also the CFO for the Herefordshire and Worcestershire Community Mental Health Trust. I've also got welcome to Ross Dowsett, who has the unenviable task of shadowing me today. He works for Care UK and is learning about how the NHS functions and what it does. So welcome, Ross. I also have to make a point about I had originally had the apologies from Julie Moore, but as you can see on the screen, Julie is here. She is recovering horizontally from back surgery, so thanks for coming, Julie, and and it reinforces the commitment of our non-executives to the organisation taking things forward. So welcome, Julie. We'll understand if someone has to plump your pillows or whatever it is later on. And as usual, at the beginning of our meeting, we start off with a story about our patients or our staff. Important to do this because it sort of grounds our conversations for the rest of the meeting in reality. And this morning we've got Elaine Stafford. Welcome, welcome, Elaine. I think Paul is going to introduce this item.
Thanks, Chair, and yes, welcome, Elaine. Elaine is one of our bereavement nurses, so we'll tell the story, quite a poignant story, of a gentleman who sadly passed away in our care. But this is related to also the use of language and also valuables of a sentimental value, and something I'm particularly cited on in the Trust at the moment around property of our patients. So I'll hand over to Elaine to tell the story. Thanks, Elaine.
Thank you. I'm just going to share the slides. Everybody see those?
Yes.
Yeah. Okay. So I have permission from Graham's son Paul to share this story with you. Graham, who is Paul's dad and Dorothy's husband, came into our care on the 3rd of August and died suddenly later that evening, and he was 86 years old. When Paul was a little boy, he was about 7, and he kept walking past a jewellery shop and saw this lovely silver crucifix that he was desperate to buy for his dad for his birthday. Not really knowing the value of money, his mum knew how much that he wanted to buy this for his dad and contributed towards it with some of his pocket money as well. And when Graham received this as his birthday gift, he never took it off. So Paul and Dorothy very much remember Graham having the crucifix on his neck, around his neck, in all of the photographs that they had of him. When Graham died, Paul and his mum couldn't be with him, but they were allowed to come in and say goodbye to him on the ward, and he wasn't wearing his crucifix. And Paul told me that he even felt under the pillow and it wasn't there. So the other The other issue for Paul and Dorothy was that Graham died very suddenly on being transferred from the A&E unit onto the medical assessment unit. When he arrived on MAU, he had suffered a cardiac arrest and he was unable to be resuscitated. And some of the language that was used about working on him, about making a resuscitation attempt, some of the language that was used in the two departments about him being conscious and alert, the care and comfort round, his observations were stable. His family said goodbye to him in the ambulance because of COVID. They couldn't come in with him in the ambulance, and he telephoned his wife from A&E, which was the last conversation that they'd had, but they didn't really know how Graham was. And this is just an example of some of the acronyms, some of the abbreviations that were used. So what we did was I had a conference call with Dorothy and Paul, and I started at the beginning of his journey when he came into the ambulance and came into our care. And I explained all the different acronyms, all the different language that had been used and what that actually translated into. And a lot of it was about piecing together the events that had led up to him having a cardiac arrest and dying, and answering any questions along the way and any queries. There was in fact a question from Dorothy. She was led to believe that he'd had a fall. And then, of course, lots of questions came from that about whether he'd banged his head, and that had led to other things. But I was able to reassure her that he hadn't had a fall in hospital. The other thing that we had to look at was that the crucifix was missing. And looking through all of the notes, there were property forms, but they hadn't been completed. Nobody had documented that the crucifix had been removed in the medical notes or in the nursing notes. So I went up with some of our bereavement team to A&E. I don't know if you can see that picture in the corner. It's not our A&E, but I don't know if any of you know the nurses' station layout in A&E, under which are a number of cupboards, and they have lots of green property bags. Normally with valuables, they would be removed if they needed to be removed and put in the safe, and there would be a record of that, and that wasn't the case. And what I sort of approached was a bit of a staff attitude around, okay, well, you know, and I understand some of this. We were trying to save his life. There was an attitude around ownership about, well, you know, if you come in wearing valuables, we can't be responsible. And the interesting shift in that attitude was when I gave people the narrative around what that crucifix meant to this family. So what we're doing now is we're using some of the stories that are coming through the bereavement service and the narratives to provide, I guess, the meat on the bones. One of the big things that we've changed in the team is, with me being a nurse, looking at the named nurse kind of concept with the bereavement officers. They now have caseloads, so they only deal with a certain number of relatives, and they are their relatives to deal with. So they know everything about those relatives and about where they are with the process, what's happening with belongings and valuables. We're building on maintaining and making stronger relationships. Believe it or not, our relationship with the mortuary wasn't as strong as it is now, and we're looking also at lots of processes within bereavement and how we're all involved in processes. We're a strong team. We're listening to feedback from relatives, and one of the things that we're doing is sending out positive feedback we are getting an awful lot of very positive feedback, which I then feed back to the ward managers, the matrons and the divisional directors of nursing, which is received really well. And I know it's, you know, a lot of the time you're trying to answer complaints and datixes, and it's really important to know that we're getting this part of the journey right for people. So we did, missed a slide. We did a study day last week at the university, because one of the issues was that our student nurses, the decision was made that they came to work with us in the first wave of COVID. And I remember the lecturer who wanted me to put this study day together saying she had a phone call on the first day from one of the first year students saying, "I've had 7 deaths today." And she realised that there was this huge gap in education, in understanding about death and dying. So in that study day, we talked about the language that we use, in particular abbreviations and acronyms, but also the language we use around death and dying. You know, we do use words like passed away, and we talked about those kind of words and that language and how that might be also interpreted by relatives. We talked about the process, and we've rewritten the bereavement booklet so that it keeps up with the times, which are, as we know, virtual and digital. We also had some sessions on different people's roles within the bereavement service. I think we dispelled quite a few myths and mysteries that are around death and what happens to patients when they leave our care on the ward. And part of that was a virtual tour which was done of the mortuary, which was videoed, which everybody found really interesting. That would normally be done in person, but because there were so many students and because of the way we're having to work, that was done virtually, but they got a lot out of that. And we also addressed some cultural and spiritual needs from the people that come into our care. So some of our future plans within the team are looking at policies and procedures, and you may or may not believe, but we have 2 different property forms on 2 different sites. So that's one of the things that we're going to address. Unfortunately, we don't really have a property service. We don't have a lost property service. We have our amazing complaints and PALS officers who tend to be the people who are responsible for investigating when something gets lost or mislaid. But that is a little bit of a gap. We are learning from feedback. We're currently doing the NACEL audit, which goes on till October, and then we'll be looking at addressing our own end of life feedback to get to understand what we need from the relatives themselves. We're going to get onto everybody's trust inductions, not just doctors and nurses, but bereavement affects everybody, and talking to people, it's a part of a lot of people's roles. As I say, we've been working closely with the mortuary and other teams looking at mapping potential delays and looking at a whole process approach and looking at where we can make that much slicker for the families. And just my last slide is, at the end of life, when somebody that's in our care has died, we only have one chance to get it right. Thank you.
Thanks, Elaine. That was excellent, and thanks for the work that you do. Could you just tell me the thing that is on the edge? Did we find the crucifix?
We did, yes.
Oh,
we did. Yeah. It was in a cupboard.
Yeah.
On MAU in a blue hold-all bag, because I was fortunate enough to found it, and I burst into tears like I am, like the person I am. And it was in a zip pocket, inside a zip pocket, and we only knew that it belonged to Graham because it had some of his medication inside with his name on.
Right. But it does kind of reinforce how important what might be described as kind of minor sort of administrative procedures and processes can have such a massive impact on individual patients and their families. I think Paula wants to say something.
Yes, thank you, Chair, and thank you, Elaine. That was excellent. I agree around the valuables. There have been a number of incidents that we're looking into within the trust about how we care for people's property, and it's all well and good saying don't bring valuables in and don't bring your mobile phone and don't bring an iPad, but actually in an emergency situation they grab the nearest thing to them and they come in. So it's about how we help those patients and the families to ensure that those are kept safely for them. But it isn't just about those sort of valuables. Somebody's lost a jacket recently that was so important to them, that it was important to them, and we've got to realise that. So, Elaine, I know you're doing some work around the property book and the property forms, and realising there's 2 different ones on each site. And I know that Lisa Marushenko, before she left, was also looking at that. So if you can link in with Jackie and make sure that we're not duplicating,
absolutely,
and that we get this process absolutely slick. So that everybody knows what to do. We have put posters up as well in all wards around that, and we've put a sentence in the letters for elective care so that people know where and when and what they can bring in. So we have made some strides, but we've just got a bit more to do. And then obviously I think the language that clinicians use, we also need to be making sure that Mike and I met with some relatives this week, which was again quite heartbreaking. So lots of lessons learned there, and we'll take that forward. But thank you, Elaine, that was excellent.
Thank you.
Thanks. I've got a few people now who want to. Anita.
Thanks, Chair. Elaine, thank you again. Want to echo the thanks of Paula and Sir David. I think that's a really, really important story that you told, and I'm so delighted that the crucifix was found. I mean, that was brilliant. But as Paula said, there's an awful lot of learning there. The whole thing around end of life and bereavement, it's something I know a little bit about because I actually worked as a bereavement counsellor for a while, and one of the things I'm really conscious of is that it's an easy thing to say that we need to do a little bit of training about cultural differences and social differences, but actually that's a really hard thing to do because it's such an emotional time for a family or an individual, and some of the rituals or things that are important to people, they may be to do with religion or culture. Actually, sometimes they're to do with the family, that a family wants to do things in a certain way, and we're not going to know that in the early stages. So I think it's absolutely right to do the training that says, make sure that the nurses are conscious of this. But I just wanted to kind of ask that as we sort of work to make this area, us even better in this area, let's make sure that we talk to patients about what would have made a difference to them, what could we have done. I mean, you've highlighted some really good things there, but actually it's only by talking to patients and their families that we're actually going to know and get even more sensitive and even more compassionate in those days. But a really good story. Thank you.
Thank you.
So I'll let you respond to all of this, Elaine, at the end. I've got Julie Moore and then Sharon.
Thank you. I was just going to say, Paula just said, we advise people not to bring their mobile phones in, and in this day of COVID, I don't think that's on anymore. I've just, on my recent experience, had an extended period of time where the only link I had with the outside world was my phone. So maybe we need to look at different ways we can do things, like maybe we stick a sticker on with somebody's name on that's almost impossible to remove, or whatever, but to get some advice on how we can make it more secure, because I can tell you I would not be parted from that. First thing I wanted coming round, and because when visiting's restricted, it's your lifeline for patients now.
Thanks, Julie. Sharon.
Thank you, Chair. I just wanted to say thank you actually for bringing this to board today, because I think it's such an important area, and sometimes it's one that's not spoken about enough. I do a lot of work around bereavement services, so I'd be more than happy to speak to your support in any way that I can. And it's important that we're supporting people, because it's not just the end of someone's journey, but it's also clarity for the family in those final moments and helping them to move forward. So we need to get it right and get consistency across the actual whole trust when it comes to this area. I know Anita picked up on the training point. I wanted to pick up on that as well and just ask whether it'd be possible to think about getting an outside agency, so those voluntary groups who work on bereavements with families all the time, to maybe share some of their training with the trust, or maybe deliver, because they work with the families on a different side of bereavements that we don't necessarily see within the trust, and it would probably give a rich sort of overview to those staff that are taking or work in this area.
Thanks. Good point. Do you want to respond to those points, Elaine?
Yeah, I think with regards to the training, we just really flagged up about some sort of cultural and spiritual issues, but with the emphasis being on some people may not be practicing those religions that are on the form that they came in with, when they were admitted, etc. So it was just being aware, but very much having that narrative with the family about, unless of course it's a sudden death, about an expected death, and thinking about how they would like to be involved. One of the other things that we talked about was how we involve relatives when somebody has died, and how we involve them in preparing the patient to go to the mortuary. And I know Cheryl, who's our county-wide mortuary manager, is also very much involving relatives in helping beyond that. So just to give you a quick example, she had an elderly gentleman who came to pay his last respects to his wife, and he wanted to sit with her, and he said, what I'll miss most is holding her hand. And so she made a handprint with him of his wife's hand so that he could always hold her hand. And it's things like that that she's going to be asking for some money, so that she can take that forward and offer it as a service. And I think with regards to the training, Sharon, I think that would be excellent if we could link up together. That would be great.
Okay, thanks for all of that. Can I just say thanks, Elaine, for coming to talk to us today. It's never an easy or straightforward thing to do, so thank you for that. Thanks for the work that you and your team are doing, and we're really encouraged by the things that you've said. I'm really pleased that we found the crucifix, and thanks for going the extra mile, you and your team, to make that happen, because that's what makes the difference, I think, for our patients. So thanks for all of that. There are just a few things that kind of popped up there that I'll just, in terms of action, we perhaps need to follow up. One issue is this issue around the property forms, to make sure we've got a coordinated response, and that we've got common policies and procedures between the various organisations that we have. The issue around the mobile phones, I just think that needs to be pursued. I'm not quite sure how, but Paula, if you could take that up to make sure we're in the right place, all of that. And the final point, I guess, is even in the conversation that we've just had, we've identified resources within ourselves that could help that. So both Sharon and Anita have expertise, interest, and a commitment to all of this sort of stuff. So Elaine and Paula, you I think use them as much as you can, but take advantage of that, because I'm sure it'll make a richer a service that we can provide. And absolutely, levering in the resources of the community, the voluntary groups and patients groups is a vital part of what we need to do as an organisation across everything that we do. But I think this is a particularly important area. So thanks very much, Elaine, and let's hope we can support you to improve the services that we give to our patients and their relatives. Thank you.
Thank you. Thanks, everyone.
Thanks. Bye. Right, let's move on. Are there any items of any other business? No? Declarations of interest are on the website, minutes of the previous meeting. Are they a reasonable reflection of our conversations? Yeah? Yes, agreed.
Sorry, David, I just had one minor amend. I've got a couple of typos, Rebecca, that I've seen, but just the one minor amend is on page, I had it here a moment ago, I do apologise, page 9, where the action says confirm figures re last minute use of bank and agency die to safety. It's due to safety. Just to make sure. There's a couple of others, but that one I thought was worth just noting. Thanks.
Thanks very much. Any other typos, let Rebecca know, we can get them so that you're honest. Very good, thank you. Action log, Rebecca?
Yes, Chair, thank you. The updates are as in red. The one item has been complete in respect to the People and Culture Committee, so we've closed that action. In terms of the yellow updates for this meeting, majority of those were in relation to the Call Me patient item from last month. Paula was due to flag this with the chief nurse, and I know they met recently. Is there anything to add, Paula, or can we close that at this point?
No, I raised that with Mark yesterday when I did a walk around in ED yesterday, so that's closed.
Okay, perfect, thank you. Mrs. Lewis is updated in respect of the linkage with Oasis and also in terms of the electronic patient records. It's proposed that we just wait before we close that formally, that we just get confirmation of that rollout date so we can just make sure that's embedded. Mrs. Ricketts is updating in respect of the staff induction programme, and again I'll get a confirmed time scale for that. There was an action list for yourself, Chair, to raise at the next system meeting, and I'll just get the date again just to finalise that one. And in relation to the bank and agency figures, sorry, same typo, I've copied from the same place. Due to timing, we haven't got that at this point, but we'll have it ahead of the next board meeting. So I propose that we'll circulate that data once it's available, and we will then close it for the next action log if that's agreeable.
Yeah, that's fine. Thank you. Thank you very much. Let's then move on to the Chair's report. I've got two items I just want to mention. First one is that following a meeting of the Finance and Performance Committee on the 30th of June, the Chair, undertook a Chair's action in accordance with Section 24(2) of the Trust Standing Orders to approve additional infrastructure expenditure requirements for the DCR programme. Approval is required to place orders before the 1st of July to avoid cost increases and delivery dates not being guaranteed to meet the programme milestone. So I approve that. I'm looking for your agreement to that. Thank you for that. And then the second thing is just to note really, for personal reasons, Bill Tunnicliffe has resigned as a non-executive director of the board. I think we should respond to Bill, thanking him for the fantastic service he's given us over many years. He's been through the darkest times of the trust and has constantly, been a beacon of sort of good sense of focus on improving services for patients. And as the chair of the Quality Governance Committee, has done a stunning and a tremendous job taking us to the place that we are today. So can I, on behalf of I will respond to Bill in writing, thanking him for his good service, but I thought we should know. I will of course now be advertising, we'll be advertising for a non-executive director with a particular expertise in clinical services, so that we can replace him with another excellent non-executive director. Thank you. Okay, let's then move on to the Chief Executive report.
Thank you, Chair. So this report is for noting. It doesn't have a assurance level because it's a report from me for noting, but it does speak to each of the 4 strategic objectives. I'll assume colleagues have read it. First start off by echoing, Chair, your comments. I think from the exec and clinical body, the relationship with Bill was very constructive, very positive. He made great strides and efforts to bring clinical staff into the governance committee to hear directly from those delivering care, and I think that made quite a significant difference to bringing the board and the front line closer together. So I'd echo your thanks and best wishes to Bill for the future. You can see there on there's a mixture of operational and staff welfare and then strategic issues in this report this month. The performance report later in the meeting will speak, I know, to the really significant urgent and emergency care pressures, but it's also worth noting for board members that we are now starting to see a steady rise in patients admitted to hospital that are COVID positive, and I say that to differentiate between those that are coming in with symptoms and illness directly related to having the COVID infection to those that are coming in for other causes that are also COVID positive. And of course, that requires us to create space in our hospitals to cohort those patients that are COVID positive to reduce the risk of cross infection to other patients. So we've had to institute the early parts of our surge plan, as we did in wave 1 and wave 2, and we have now converted beds on the acute respiratory unit to look after respiratory related patients, and Avon 3 is now converted into a cohort ward as per our normal sort of first stage preparation. As of this morning, I think we have 14 just check my numbers, 16 positive patients in our hospitals, and that's just a gradual steady increase as the community prevalence is continuing to increase in the county. As of today, we have 294 positive cases per 100,000 of population, and that's now coming close to the England picture, which is 342 per 100,000 population. So we are now girding our loins operationally to prepare for a further gradual increase over the next few weeks and making sure that we have operational plans in place to deal with that. So that's in addition to, in the first quarter, a 14% increase in emergency access attendances and a significant increase in the number of patients that we are enabled to discharge home when deemed medically fit for discharge within 24 hours, and the standard we're supposed to work to is 98%. We don't yet have the data from our partners across the system to confirm what our actual performance is, but it is quite clear that it's nowhere near 98% within 24 hours of being deemed medically fit. So I'm sure we'll talk about that later in the meeting. It is worth saying, though, that clearly one of the key requirements of integrated care and integrated care systems, particularly working at place level, is to be focusing on the real patient safety issues that the health and care services are dealing with at the time. And if this isn't the top one, along with the restoration of elective surgery, then I'm not sure what is. So I am continuing to work with system leaders and particularly the ambulance service, being very proactive, coming up with additional ideas for how to dampen down demand at our front doors. We've had a lot going on since the last board chair. As you'll know, we've had the AGM last week, which I think was a success, albeit it's not the normal process given the need to do it via video conferencing. We've had the staff awards ceremony on Friday evening, which I know from our staff's feedback was also very positive. And just to note, we continue to work with colleagues around developing provider collaborations, as noted in my report there, working with Quiet Valley, colleagues in Coventry and also in South Warwickshire. We had a meeting with the Coventry leadership team a couple of weeks ago just to make sure that we're working towards the implementation of the board's strategic approach to partnerships and making sure patient safety is not compromised as we move services more closely aligned with our colleagues at University Hospital today. So I'll pause there, Chair. I think the last before I pause, actually, the last thing just to note as a follow-up from last month's meeting is that we now have a start date for Christine Blanchard, our new Chief Medical Officer. She will start with us on the 7th of October, and Graham James, the Deputy Chief Medical Officer, will be acting up in the interim. Happy to take questions, Chair.
Thank you. Simon.
Thanks, Chair. Just a couple from me around the Bain conference, which I thought went very well, the annual conference we had. I think there was a charter due from that, Matthew, if I'm correct. Do you know when that's going to be coming to board for us to see and to sign it off? And then just a question to you, do the network chairs ever come to board to sort of discuss or present to us what they've been doing? Because I think that might be useful at some stage. Again, this is probably just me being new to the trust, but it would be helpful, I think, at some stage if we could have the chairs come and talk with us.
Yeah, absolutely, Simon. I'll ask Tina to answer the first question, but I think with the Chair's permission, I think we should sequence that into our future board meetings so that they can share their reflections directly with board members. But Tina, in terms of the charter?
Yeah, so we just wanted to spend some time, Simon, on working with colleagues across the trust to develop the charter, allowing them to have input to that. So we're intending to bring back the draft to the either September or October board for sign off.
Okay. Thanks very much.
Thanks. Any other questions in relation to all of that? I mean, just to reinforce I thought the Bain conference was excellent, but very challenging. You know, it's all very well listening to people. We're going to have to do something about some of these really deep-seated issues in our organisation over the period. But the conference itself was great. In fact, I can't remember, certainly since I've been here, there's never been a conference as large and as with so many people engaged in it than we had on that one. So it's great that there is energy there that we can take things forward. And just to mention the staff award, which I thought was an incredible event, and it's I mean, one of the things that I would say that, and I've said it to a lot of people, when I first came here, a member of staff pointed out a photograph on a wall of the 2016 staff awards, and her response to me when I asked have we had them since was, we've had nothing to celebrate here since 2016. And I think for me it was a very poignant comment that she made about all of that. So building ourselves up and congratulating people and supporting really good practice, of which there is lots and lots in this organisation, is a really important part of rebuilding our confidence. I've got Wakar who wants to say something, then Matthew, and then we'll move on. Wakar.
Yeah, thank you, Chair. Matthew, in terms of the alleviating the high demand on us for our emergency and urgent care services, are there any results that we can see that the work we're doing through our system partners through the ICS forums, are there any outcomes? Are there any results at all?
I think Wakar, the difficulty is that it's quite difficult to see whether any initiatives at the moment are really driving down demand. For example, we're seeing the 111 service referrals direct to ED now at twice the level that it would on average be. So it would be about 12% on a daily basis. The last week or two it's been at 24% on average. And of course that's why we're working closely with the ambulance service to look at alternative pathways for the 111 service to be able to refer patients to, rather than referring them to the emergency departments. But of course the minor injuries utilisation is still too low. It's at 70%. If you add in Kidderminster minor injuries unit, it's at 80% of the equivalent activity in 1920. So that's another area that we're working with partners to see what more we can do to shorten waiting times at the minor injuries units, which do get up to 2 hours at times. And of course, people will be, voting with their feet if they're thinking the waiting time here is no worse than an emergency department. Well, I'll go there because I know I'll be seen by a doctor and so on and so forth. So you get those kind of behaviours playing into it. I think one of the things that we do need to accelerate is the relationship between the ambulance service, 111, and the 2-hour community response teams, and also making sure that general practice is available for referrals from 111. So I think we're seeing the demand outstripping any impact of the work that's been done thus far, and I think that's why we're really coming together to say what more can we do to address this growth in demand, which I'm sure is unmet need in some part, but it is also, I think the evidence suggests, partly due to the behaviour of our public, who believe that they can't get a general practice appointment and know that the lights and doors are always open and on at the emergency department. Paul will probably talk to this later, but we had a colleague from the NHS England team come to the Worcester site yesterday to audit the patients that were being brought in, referred by GP into our ambulatory services, and we await the results with interest. But I think there is a strong view that some of the patients that are coming, particularly those that are walking, should be being dealt with in other parts of the health services locally. And that really is the key for us to get right, is making sure that people have viable, easy access alternatives rather than coming to the emergency departments and waiting in some cases a long time. Obviously, we'll touch, I'm sure, on ambulance handover delays and delayed discharges and those patients later in the meeting. But I think the demand is certainly outstripping the impact of any of the initiatives at the moment, and hence why I think we really need to accelerate and get our focus right on doing what we can to reduce demand.
Okay, Richard.
Yes, thank you, Matthew. And I understand your answer, of course, but I think in previous meetings and even in the last Finance and Performance Committee, it was also about, do we really have a shared understanding of priority and urgency on the issues? So can you say something about that?
Yeah, I think that's right, and I think one of the things that we've instituted now is, if you like, a mirror image of the COVID incident management response for urgent care across the county, which all partners have signed up to. Albeit we need to make sure that we've got decision makers and the right seniority at both the bronze, silver, and gold meetings, and making sure that we then see action at the speed that is required. The Pathway 1 capacity challenge, which is responsible for a high percentage of those patients that are not going home when they should do. Recruitment is underway, but the importance of getting people in as quickly as possible, and whilst the capacity isn't very easily, finding alternatives, bringing in other agencies that can provide domiciliary care to supplement the capacity that is existing at the moment. And my sense is that we really need to make sure that people understand the clinical risk that is being carried by the ambulance service and the emergency departments of our organisation, and make sure everybody sees that as their priority. The Integrated Care System Executive Forum earlier this week, we had an update from both counties in relation to urgent care, and I think I made it very clear that I didn't feel that we were in the position to be confident that we had a plan that was going to be able to address the current issues that we're dealing with, and that's partly about pace, Richard. So I welcome your comments and your challenge, because we need to deal with this stuff today, not wait a few weeks, because it's clinical risk that's being experienced. Not only clinical risk, but also staff experience and staff welfare risk as well. Chair, the other thing I just wanted to note was a note of thanks for Richard Haynes and his team, who had the week of all weeks last week with both the annual general meeting and the staff awards. So just a note of thanks to Richard and his team for the fantastic work that they put in.
Here. Fantastic work, Richard. And I've never seen Richard so stressed. So let's all be nice to Richard for a while. Okay, well, thanks. We will come back to the issue about urgent emergency care when we get on to the another report. But we just need to hold some of that as we go forward. So thanks for that. Let's then move on to. So we'll note that. Let's move on then to the annual plan priorities 21-22. Lisa.
Thank you, Chair. So I'm going to take the report and the plan in the appendix as read. In summary, the report sets out our annual plan for 21-22. The plan before you has been developed following a review of last year's priorities, and that includes the refresh of last year's plan, which was undertaken in November following the first wave of COVID, where we adjusted our priorities and refreshed the plan accordingly. We've undertaken a thorough review of our trust transformation programmes and also married the plan against the risk in the board assurance framework. And of course, we have the developing ICS around us, and we've tried to reflect that in the substance of the plan that's before you today. So as usual, the plan's structured around the Trust's 4 strategic objectives and identifies the key priorities and success measures associated with each of those strategic objectives. So in summary, we're presenting the plan today to board for approval.
Okay, thank you. Any questions, comments? We have had bits of this before, so it would be no surprise. I mean, sorry, Colin.
Thanks, Chairman. My question relates to how well integrated the various components of the annual plan are, because we list out a series of very important initiatives to do with the quality of our care and our patient experience, without any reference to the financial implications. And I wondered, are we therefore assuming that they are cost neutral, or if they're not, is there some compensation for that in the finance, the use of resources element of the annual plan? That was the first question, and sort of linked to that is, and Rob can correct me on this, but as I understand it, the messages coming from the Centre about H2 funding seem to be implying an efficiency of something like 3% as opposed to the 1% that we've built in. So do we need to be more ambitious in terms of reducing our cost base in the short term?
Yeah.
So, Colin, so if I respond to that, and I don't know whether Rob then would like to add to what I have to say. So in terms of one of the key priorities under best use of resources, one of the key objectives for this year is to develop our medium-term financial plan. And that plan will bring together all of the elements that you have actually identified and bring those into one plan where we can actually look at all of those elements and then project forward what we need to do as a trust to make sure that we're sustainable in terms of our cost base and our finances. But Colin, you are right in identifying that the H2 planning indicates that we will need to make an efficiency of 3%. So there's much more work that the trust needs to do to achieve those within its financial plans through our H2 planning round.
Okay, thank Richard. We'll come back to that, Richard.
I think Colin has addressed part of it. I'd like to ask a question to Matthew. If because you know this is our plan and we've read the objectives. There's lots of objectives. If you had to pick 3 things you really want to get done this year, which are the 3?
So I think the absolute top priorities for us, Richard, if we were to pull those out, are urgent emergency care and resolving not only quality performance but also the massive extra investment that we have to put in on a daily basis to manage patients that we shouldn't actually be looking after. The second one is the restoration of elective and diagnostic services, because that is also crucial from a patient safety perspective, but it really will drive some of the points that Lisa's made in relation to the productivity and also the cost base, making sure that we're sweating our assets as effectively as we can. If I put aside the capital schemes, I think the third biggie for me is making sure, we'll be talking about it later on, is that our maternity improvement plan is implemented absolutely in full. So those are the 3 quality performance. I'm going to put a 4th in because clearly the outputs of the board development session on the financial plan is going to drive our next 3 years transformation of the organisation. So those top four, if I put aside the capital schemes, are really the ones that stand out in the plan from my perspective.
Thank you. And so I think it's really great that you could articulate that, Matthew. Maybe it's also a good idea to kind of have some communication around those priorities wider in the trust.
Yeah.
Thank you.
Yeah, and it's just to avoid all doubt, those are also in Matthew's personal objectives, those particular ones. Okay, Wakar.
Thank you, Chair. Lisa, well done to you and Joe in terms of developing the strategic objectives. And I really welcome the additions to forward behaviours, which we discussed in our committee meetings. So really welcome that. Just a question: I was reading the objectives and I couldn't see that it should be under improvement. I couldn't see the PEP schemes by divisions or the PEP delivery. Has that been included, or is it just been missed out?
I believe that's under the best use of resources section in terms of the achievement of the medium-term financial plan and also the productivity and efficiency schemes.
Right. Yeah, it's goal 3.2, Wakar, on page 9 of the report.
Okay, great, thank you.
Okay, I'm going to ask. I was going to ask Rob to talk about the finance, but I've got Anita again. Sorry. Anita.
Yeah, thanks, Chair. I think Richard and Colin have raised the point about the financial aspect, so I won't go into that. The one thing that I wanted to say, I hate to say this because this is already a very long list of priorities, and it's really helpful to see Matthew's, his ability to really be clear about what the top ones are. And I hate to be the person that's always banging on about this. Environmental sustainability. There was something in the HSJ about yesterday about trusts or systems having to publish carbon footprints later this year. And there is one of the things that concerns me. One of the things I want us to be really clear about is that as we restore and recover, as we look at transformation of the way we do things, there are things that we can do that will aid our environmental sustainability, and or we could tackle the same problem in ways that will actually make it worse. And therefore, I don't see it as an additional priority. But just like finance, I do think it needs to be a lens that we apply to everything we do. And there's no reference to this at all, so it was a suggestion. Thanks,
Matthew.
Yeah, thanks, Anita. And yeah, we're seeing quite an increase in correspondence in relation to sustainability and the environment. And I think one of the elements that we've asked for in the development of the estate strategy is really to look through that lens. We have our estate strategy coming to the Trust Management Executive next week. I know that Paul was keen to make sure that it wasn't just a narration on our buildings. It was much deeper and more comprehensive than that. And I suspect that we'll be looking through the lens of sustainability next week when we consider the estate strategy. We will, though, over the period, need to develop a sustainability strategy. But I think it starts with understanding what buildings we have, what utilisation we have of those buildings, what's the energy implications, etc. So to provide some assurance that work is starting, I think we're quite a long way from being where I think the expectation is.
Okay, Simon.
Just to back Anita up on that point, and I know what you say, Matthew, about estates, but I think this goes further across the trust. It sort of needs to be core, ingrained in everything that we do and everything that we're considering. And I would think we would need to have something in the annual plan about this, because it is silent on it. And like Anita, I saw in the HSJ yesterday that systems will be asked to map out their carbon footprints. But I think if we genuinely take this on board, this is something that makes it attractive to staff who might want to come and work, because there's a lot of staff regard to attract. They could go anywhere. So I think we are missing a trick here, and I think we really, at this stage in this annual plan, ought to be making some reference to it.
Okay, I'll bring all this together when I sum up, unless Colin stops me. But is Rob Mackey, do you want to say something about the financial elements of this? Because in a sense, if you read this, it sounds as if we're going to spend the year kind of planning for the next 3 years in financial terms, as opposed to really making inroads in our cost base this year. Rob?
Yeah, it's always a difficult act, isn't it, to balance what's overtly in the plan and what's actually built in through your governance arrangements around good control and the like. I think for me the critical points are here that there is a section, as Matthew said, which is around the efficiency part, which talks to reductions in agency, and then the PEP plan on top. I know you've had a board session, and I've been involved to a degree so far with the work around medium-term sustainability, which is going to be absolutely crucial. That's been worked up with some pace, and I do think that there is a question of focus here, focus and what is achievable, and setting a realistic target. I think probably some of that will come out of the strategy, because I think that there's an absolute piece about positioning. I think the other piece that we've got to draw in here as well, and Colin will be privy to some of this, is there are some quite big discussions, but early stage, around the system and how does this map through with the system ask in terms of the overall efficiency that we're delivering there. I think that has to come together in the course of the next couple of months, actually, and there is a lot of work to do. I think it'd be hard to put that in specific detail into your plan that you have here, and there's an element of you've got to get your plan out, but there is definitely an issue about focus, I think.
Okay, I mean, I'll sort of, thanks for the plan. I know it's difficult to crunch all of this down. My assumption is, though, that the executive team are confident of its delivery, or she wouldn't have sent it to us. So I don't want to kind of go on about that. But there are two issues, I think, that have come out of the conversation, which I think are particularly important. One is the financial bit, and if you think about what's it? I get confused. H2, isn't it? I don't know. H2, is that I thought it was a railway or something. Anyway, but whatever it is, the second half of the year, we've got both an increased, as I understand it, an increased efficiency requirement and a reduction in the amount of money available through the ERF. The fund. So both of those, I know there are discussions going on at system level around how we can manage all of this, but that must have an impact on the annual plan. So when we get the first report on the annual plan, presumably next September, we need to integrate into it what the impact of all of those things are on making it a reality. So that's the first thing, and then the second thing is this issue about the environmental impact of what we do, and we've sort of skirted around this a few times in the conversation. And from what I've seen, there is quite a lot of stuff going on actually around the trust about it. But I completely take the point that it is a thing which there is a lot of energy in the organisation for. Not from everybody, but there is a lot of people who are really interested in this. And I agree, it does make us a much more interesting employer going forward. So two things, I think. First of all, I'm not sure whether just adding environmental issues onto the annual plan will do what we need it to do at the beginning. I think we need to think about what the environmental impact of doing what we've said we're going to do here would be a helpful one, and perhaps we can report that in September if we've got it. But it seems to me the board, we need a proper discussion about this, to really get underneath all of this. So I would propose that probably if we have a discussion about an environmental strategy in sort of October time. It may not be the finished thing, but will give a focus to people working in the organisation now, so that we can have a really good discussion about this to make sure we set it in the context of all the other things that we're doing. So that's what I would propose. Okay, well, thank you very much, Lisa, for all that, and let me just get right. We approve the plan with those issues attached to. Okay, let's move on then to an item which is particularly relevant given the conversation we had earlier, which is about which is an end-of-life strategy which you will have received, and which kind of reflects, I think, or kind of makes it more real in terms of what we've heard earlier on this morning. So, Mike, are you going to talk to us about this?
Yeah, so, I mean, you said earlier that there are some services which are really excellent in Worcestershire, and I think our palliative care team are one of those who've got a really great reputation. We still have, well, I think, too many people dying in hospital. Worcestershire is about on average with the rest of the UK at about 45% of the population dying in hospital. So the focus of the team is to try and see what we can do to make that period of care the best it can possibly be. We've seen a number of initiatives, as outlined in the paper, that they've introduced, which are working really well across the trust. So in the last CQC inspection, the end-of-life care was rated as good, and their aspiration, as for all of the services, to be outstanding. So they produced the strategy which is attached and outlined the things that they're doing to try and ensure that we get to that point. So I'm happy to take any questions on it, but I think they're doing an excellent job, and they're some of the stars of the organisation. I'll stop there.
Okay, thanks, Mark. Any questions? Richard?
Yes, and we've briefly discussed this also in QGC, Mike. So first of all, I think this is a great service, and it's great to see that they have really adopted Matthew's principle of better never stops. You know, even if it's good, we'd like to make it better. So I think that's a compliment, first of all. Secondly, you know, a big part of the emphasis also in the system work needs to be on reducing the 43.3%, because too many people die in hospital that shouldn't be there in the first place. And I'd really like to understand, are we, let's say, maximizing our collaboration with system partners to lower that percentage? And that's one of the questions. And the second one is, and you answered this, Mike, in QGC, but maybe you can repeat the answer for others. Are we really giving enough attention to the fact that people in different cultures require different things at this stage in their life?
Yeah. So if I do the first one, as part of the Clinical Practitioner Forum, we've been looking at how we use the 2-hour response, which is being developed, to try and avoid bringing people in towards the end of life and putting better support in at the community. So that's a focus between us, the Health and Care Trust, and the primary care networks. So that is starting to roll. There's a lot of money being invested in it. We've just got to work out how we get that system to work best for us. Interesting, in the first few months I was here before COVID sort of put lots of stuff on hold, we were having discussions with the Community Trust about how we put better support into the nursing homes so that we could provide them with clinical advice to keep people in the nursing home. And that's been reopened and reinvigorated. So yes, there is a lot of work going on to see how we better plan it. The RESPECT system, which has been developed across the whole of the ICS, is also part of that focus, and there's been a big push to get the RESPECT documentation online now. So up to now it's been a paper document, so if it isn't easily visible you can't see it. There's a move to get a digital one that will be accessible to all practitioners, including the ambulance service, so that they know what the wishes of the individuals are. Which, of course, if you go to see somebody whose mental capacity is not optimal, they may not be able to express it effectively. So all of that's in place. And absolutely the palliative care team are doing a lot of work with partners and with the volunteers to look at how we change cultural approaches. We're very lucky with our chaplaincy service, which is truly multi-denominational. We've got an imam who covers off the work within the trust, plus a variety of Christian chaplains to support the different aspects of life. But the cultural bits, even within that, we're trying to work through with community groups. So all of that is part of the work that the palliative care team are doing. So that's helpful.
Okay, thanks. Wakar.
Mike, just in relation to the conversation we're having, the bereavement app that we launched in April 2020, what's the learning from that? Because it's 1 year on. I mean, do we have any thing that you're able to share?
Well, the bereavement app is really around reasons behind things. So at present with COVID, a lot of the messages that have come out are bits we learned around COVID rather than the more generic stuff that we need to learn, because so much of the bereavement experience has been around COVID and not around the generality of end-of-life care. So I think that will start to produce stuff over the next 6 months as we get back to something like the new normal.
Okay, Matthew.
Yeah, thanks, Chair. And as you can imagine, it's a particular interest for me, given that this was my clinical specialty for many years. I think the conversation we had at Trust Management Executive was very interesting, because we did debate whether we were doing enough to promote advanced care planning for patients that are coming that are clearly likely to be in their last year of life, and I think the evidence suggests, I think it is 2 hospital admissions within a year. If you're over 65, suggests that's the likely scenario. So we agreed that what we would do is focus on how we collected data, shared data in a way that Mike's articulated. But we do also have to make sure that, you know, for our ambulance service colleagues, that they are clear that if patients have an advanced care plan or a respect form, that overrides a GP who hasn't seen a patient in a nursing home just saying to the ambulance crew, you must take this patient to A&E, because that's the reality of what we see. So this is our end-of-life care strategy. Fantastic for what we're doing. But really, it's about the county's end-of-life care strategy and how that helps to make sure, as Richard, you said, that people die in the place they would want to die, as opposed to dying in hospital. So I think there's still more to do. I think this is a really great start for us internally, but I don't think we're there yet as a county being able to confirm that we're meeting really all of the needs and expectations of our population.
Okay. Any other comments on this? I mean, I'm going to sound slightly churlish now, and I don't mean to. In the sense that I think this is a fantastic piece of work, and within it, there's some really, brilliant stuff. And if we do it, it'll make a massive difference to patients and services. And all credit to the people who have done it. But my issue is about whether it goes far enough, which I guess is the point that Matthew is talking about as well. It's almost a whole system plan, but it isn't. It's almost there, but it doesn't do whole system. And part of my anxiety about the plan was that it doesn't sufficiently take our strategy into play. The way it organises itself and the way it talks about things is basically a national template, as opposed to our organisation strategy. And if we were doing with our organisation strategy, this would be a whole system plan. So, great that it's been done. I'm sure it'll make a big difference to individuals, and all credit to the enthusiasm of the team that's done it. But I do think there's another iteration of this that's required, which is much more focused on our our kind of strategy around thinking whole system and thinking about how we can make it all work. It's nearly there, it's just not quite there. And but I think as far as it goes in its own terms, I think it's an excellent plan. Did I sound churlish? I didn't mean to be, but I just think that I don't know whether that's something you've had a conversation about, Matthew, but it struck me having reflected on it.
Yeah, absolutely, Chair, and that reflects, I guess, my points much more articulately made, and also the discussion that we had in TME. I guess the Worcestershire Partnership Board meeting on Friday, I suspect we'll get into some of this during the discussion there.
Okay, thank you very much for that. Mike, do you want to say anything finally before I?
Well, no, I accept all of that, and I'll take it back to the team, because I know they are working with the Health and Care Palliative Care team in St Richard's, so I'll get them to beef it up on that basis.
Yeah, and to be fair, they do reference it. They talk about some whole system stuff, which is fantastic, county-wide working. But it would be great if it was one. If they actually owned it as well, and it would just be a brilliant step forward for us all. And connected to that is, of course, what it doesn't talk about is the financial consequences of all of this. And of course, what we know is that I think it's 70-80% of all healthcare expenditure is spent in the last 6 months of life. So this has a big financial consequence potentially, but it doesn't. So when you're having the next iteration, if we could think about that as well, that would be great. Thank you. But from the point of view of what we've got in front of us, and as it is a kind of a step forward and a statement about future direction, I think it's excellent, and I think we should approve it. Agreed? Thank you. Let's move on then to the integrated performance report. Vicky.
Thanks very much, Chair. So this is the integrated performance report for May, and it's here for assurance, having made its way through Trust Management Executive and the various subcommittees of the board. Just in terms of the format of the report for this month, you'll notice some further enhancement and changes. So the data quality marks have been finessed even further using a risk matrix approach across each of the sections. Also, as part of the benchmarking graphs, we've included an arrow for illustrations of where we're moving across the different peer groups in relation to those performance indicators. We've published the maternity indicator suite following the quality review that was in place around that particular set of indicators. And the quality and safety section of the report also includes a headline performance measure sheet, just so that we can have an at-a-glance look. However, that does not follow the common cause variation that we usually use. We've also included for reference as one of the appendices the RTT simulation exercise, which is seen as an exemplar of good practice by NHSI and has been done by Chris Redding, one of our business intelligence analysts, who's a real superstar for us, Chair. In terms of the assurance levels in the report, there's been no changes at all, with the exception of the maternity section, which has moved from an assurance level of 6 in March 21 to an assurance level of 5 today. And that's based on the work that the data quality and business intelligence and maternity team have been doing, supported by Paul and Paula. The report has an overall assurance level of 4. In respect of the key headline areas, Chair, and they relate to emergency and urgent care, which we've discussed earlier on in the meeting, the recovery and restoration of the elective programme, including the RTT position, and a focus on those people that are waiting over 52 weeks and the cohort over 70 weeks. The maternity work and the conclusion of that maternity work. The workforce numbers in terms of their success around getting a back to basics campaign in place and improvements in appraisal levels. And also you'll see some of the challenges around the bank and agency key indicators. The finance position, which Rob will talk to in detail, which is about the financial framework that's in place for H1 21-22, the financial performance for the organisation, including the cash and capital position. And Chair, if I may be so bold as to ask if we could focus on the quality, people and finance piece first, because Paul's had to just drop off to do an urgent system call, and we'll come back to the operational performance piece at the end of this section.
Okay.
Thank you. So do you want to hand over to Paula and Mike to take us through the quality and safety piece?
Thanks, Vicky. Well, there's not much to say about infection control. We're still working through our non-COVID infection control targets. We're still waiting for the national response about what those targets should be, so we're working on our previous targets, although we have put ourselves some locally set sort of an ambitious one around E. coli and reducing a further 10% on those. So just working through those issues around C. diff and E. coli, and C. diff especially because obviously we want antibiotics prescribed in the first hour for sepsis, but that also can have an impact on C. diff as well, so we've just got to balance those two targets. So happy to take any questions on those.
I think there's too much stuff in here for us. I think we need the executive to identify what the key issues that we as a board need to consider. There's just too much. You know, we could have a conversation about any of these things, but it's just those. We need a bit of focus on this. What are the things that the executive feel we particularly need to think about as a board at the moment?
Chair, if I can just step in, I think the key elements are in the executive summary, really. But if we spend the time today focusing on, I think the finance, urgent care, restoration, because I think unless people have got particular questions around the quality and the people indicators, I think those three are the ones that carry for us the most risk, particularly in the consequence of age.
I mean, my assumption is that all of the issues that are in here have been considered by the subcommittees anyway.
Yeah.
But nevertheless, there are things that collectively. So let's talk about the money then. Rob.
Yeah, thanks, David. And we've had a bit of an intro into this from an earlier piece. So I've got a bit of a summary. There's probably about three key things I do want to pull out, but I just need to lead into that slightly. So just in terms of what you've got here, it is rather complicated from a positioning perspective, and that does just absolutely tie into the problem we've got with the current H1 income arrangements. The key message was, though, that as of month 2, we're doing slightly better than we had expected to be doing. And that was a combination of factors. So we were slightly spending less than we'd thought, but we were seeing significantly more income around the elective recovery fund than we had originally planned for. Now, the system complication was, at H1, we had a system gap of 6.4 million, which means that was just sitting as unmitigated risk, and there was an agreement that we would see how things went effectively and offset some of the gains as we went along against some other contingency arrangements in place. Now, what's happened in June is there's been a resubmission of the plan. So when you see the month 3 position, it kind of catches up with a revised position. The key for us, though, was at month 2. By the time you factor in the elective recovery fund, we were running a significant favourable variance. Now, the key point I want to draw out is that with the recent national announcement around elective recovery fund, effectively they've pushed the bar up. We will not recover ERF that we expected to for months 4, 5, 6, and we'll need to see the arrangements for the year after. But that immediately puts about a £1.5 million gap into our current plan for H1. There's a bit of work to be done around that, but that's kind of the headline numbers that you need to pick up on that. The other point in our H1 plan that I wanted to draw to your attention is that we'd made some assumptions around expenditure slowing down in months 4, 5 and 6, and this was really around, we were expecting some sort of recovery and payback from the work around our staffing effectively and COVID. Now, I think where we are with COVID at the moment, and as Matthew has alluded to, some of the pressures around urgent care, I would say that at the moment is something we need to work through, because that looks like an additional risk to me. The final piece I wanted to draw out, which we've touched on, a couple of board members have mentioned, is the piece around efficiency. And I think, quite rightly, as with the majority of organisations, we had a fairly cautious expectation around H1, and you'll see from the profile here that's what we had. That does start to pick up though from month 4, and that relies on obviously planning and staff being able to do that. Now the plans are in place and we are working that through, but that feels like an additional risk that we're going to have to be sighted on. The final bit on the efficiency piece, though, as colleagues have referred to, is from the national call we had last week with Julie and Kelly. Whilst we're still waiting for publication of the arrangements and the guidance and the frameworks and the like, the national expectation is that we will roll forward arrangements for H1 into H2, but they will reduce funding for a larger assumed efficiency. Now 3% is the number that's been quoted. I think that's 3% annualised, so it should be a part year effect, but that is more than we have in our plan at the moment. So that is going to require us to look carefully at how we can increase our efficiency in the final 6 months. And as I said earlier, Chair, I think that ties into some of the discussions with the system about best use of resources. And as Matthew's alluded to, actually some of this has got to tie into how the system responds to pressures and makes things work. I would add in, I think there's a big piece here around really being clear about investments that have been promised by our CCG into supporting services, which at the moment we haven't quite landed yet. And I think there's a big risk for this organisation that we need to make those happen. But I think if you take all that together, it looks like a more risky position around income and revenue than maybe we are at the moment. There's quite a lot of work to do. I think the medium-term sustainability plan we're talking about is crucial, but that's not going to answer the problems for this year particularly. But that's about a really important strategic piece. The other things I would just touch on, capital, you'll see we've got spend which is predominantly related to schemes from last year. We've got a big programme. At this stage in the year, lots of people are working hard on that, but you'd probably expect me to say it is not without risk of delivery, but it's really important we work with that. And then finally, end on a higher note, cash looks positive at the moment, and it's great to see that we've been playing our part locally and delivering on the Better Payment Practice Code. I'm happy to pick up questions.
Thanks, Rob. Right, Colin.
Thanks. I think you've hinted at the answer to the question, Rob, but just for the sake of clarity, the report for the month might give us some assurance that our finances are improving because we're doing better than we thought we were going to do. But I guess it could either be a result of some of the good things we're doing around financial control, getting traction and biting, or it could be just that the workload is being pushed further back in time. We're not doing what we should be doing. And that actually is a real cause for concern, and I think it highlights what the chair said earlier, that finance has got to be a focus. You mentioned the word risk umpteen times, Rob, and I think that was a very clear message that we have some real issues around finance that we have to start getting to grips with sooner rather than later, it seems to me.
Yeah, I mean, I would say, Colin, from what I've seen, actually, some of this, it's a mix of that there are some really good systems in place. There are some people working really hard on this, and we've got a lot of competing priorities here, haven't we? So it is going to be about focus on the things that really make a difference. I think I'd be remiss in not using risk. Crikey, go back a couple of years, it was an 80 million deficit. So we're in strange times with funding and expenditure, aren't we? But I don't think there's a finance director that would sit here at this stage and not mention risk.
Yeah, my experience of risk, not from our current finance director, who's off sick or you, is that when finance directors in the past in this organisation talked about risk, they've talked about it's actually going to happen. So it wasn't risk, it was actually, and almost by saying risk, people have taken it as permission to enable them to do it, and we need to absolutely not to do that this time. Simon, and then Richard.
Thanks, Chair, and thanks, Rob, for that. Clearly this will come back to the Finance and Performance Committee when we start looking at what this means for the budget going forward. But just an observation, we do really need to double down on those PEPs and deliver, and not just deliver ones that are one-offs, but transformational ones that are actually going to affect the bottom line going forward year on year. And I know colleagues are working on this, but that message just needs to be reinforced, because otherwise we're going to find ourselves going backwards rather than forwards as we'd originally planned.
Yeah. Richard?
So first of all, I think Rob gave a really good summary of the situation, so I would fully, let's say, support his summary and what he's given. I think there is an element that we should be able to influence, which we will look into in more detail, and I know the team is doing, Robert, in terms of bank and agency, because we just see the drivers move in the wrong direction. That's cost. That's something that's more directly influenceable than income. Yeah, you're absolutely right about income. Both the ERF as well as the normal income arrangements are unclear and are changing as we speak. So I clearly see the same risks as you do. I think basic controls are in place and are being properly executed on. Our challenge is really in what is our management capacity to deliver some of these efficiencies. It's not just that people don't want it, it's also the combination with COVID and restoration, and so that's where I see some of the risk as well.
Yeah. Anything you want to say finally before we move on, Rob?
I would absolutely agree with that, and I know in my organisation where I'm with my other hat, absolutely those points about capacity and just staff that are worn out are really important factors, really difficult, but all the more reason for being absolutely clear and focused about what it is we're trying to do and having that plan.
Okay. Matthew, do you want to?
Yeah, thanks, Chair, and thanks, Rob, for a really helpful summary. And I think, as you say, the risk profile has increased. And Richard, I think your point about capacity and the resourcing of some of the schemes we have within the exec team been discussing quite robustly in terms of whether there is a case for, in some areas such as the agency premium reduction, a bit of investment in doer time in order to drive out the savings. So I think the active discussion about how we resource to drive out the savings is very much part of the discussion. So I just make that point that we're not ignoring the risk of capacity not being there to drive out the PEPs.
Okay, and so on the finance thing, obviously focus is an important part of all of this. There is a myriad of moving parts here, which is almost impossible for me to keep. I'm sure you've got it under wrap control, Rob, but there's a lot of things going off at this simultaneously, and working out what the kind of difference and what we have to do for each of them is mind-boggling for me as a chairman. But as I say, I'm sure you're well in touch with it. I think there are kind of series of principles here that though we just need to hold on to. I think the first one is that we need to really control our costs. That's the thing we've got some control over, and so making sure that we don't slide in any of that while all of this is going on. Secondly, we don't spend money we haven't got, and that when we want to do something, we've got a real clear source of funding for it, either internally or externally, to make it happen. The third thing is we need to avoid letting the efficiency gains that we require in the second half of the year slide away, in the sense of if we find a way of fudging it in the short term or whatever, don't forget those numbers then compound themselves the year after. And that's one of the issues this organisation has dealt with, short-term fixes, but actually the real underlying problem runs on, and it would be hideous, wouldn't it, if we went into next year with a bigger gap than we had than we've had before. So all of those things, I'm sure the executive are onto it, and I'm looking to Richard and the team to assess and assure us as to whether it is going to deliver what we need to deliver. So thanks for that. Is there anything else on this that people want to raise in terms of the IPR, whatever it's called? No. Can I just reinforce again? We just need something focused at the beginning of this that wants to, direct us to where the conversations do. And I know there are lots of things to do, but actually to get the best out of the board, we need to be able to do that. Okay, well, thanks very much.
Sorry, David.
Yeah.
We skipped the performance section because Paul wasn't there. So I'm not sure how you want to deal with that.
Is Paul still not there?
Yes, he's still not there.
Matthew, how do you want to do this?
So I'm happy to field questions until Paul returns. Obviously, he's there's the region have called each system across the Midlands for a discussion around urgent care and ambulance handovers, and I suspect that's where he's still stuck. So happy to say. I mean, obviously, I've introduced the point about urgent emergency care, and you've got the May report there. In terms of restoration and recovery, as Robert said, we hit most of the expectations that we were expecting the RF to follow, but obviously the goalposts have changed going forward. But I'm happy to try and field any particular questions.
Okay. Any questions on that? Richard, have you got a question, or are you?
Yes, I've got one question. I mean, we've discussed some of these issues deeply in both QGC and finance and performance, but I think the remaining question for me is this: there's been some good modelling work done, which is in the back of the report, which essentially says if we do what we plan to do, and if the waiting list keeps developing the way it does, we will only see an increasing waiting list and not a decreasing waiting list at the end of the year. And so the key question is, and I believe Matthew and the team are discussing that, what are we doing more than we are currently planning for to actually get into a position where we will see the waiting list reduce?
Yeah, I mean that's the killer question, isn't it? Because I think the future modelling work that the team have done, I think, has highlighted, as you say, good piece of work. But it throws up more of an issue and doesn't really, tell us a story that looks very attractive. I mean, part of the conversation that's being held at a system level, and this was touched on at the ICS Executive Forum earlier this week, is what else could be done to help with reducing waiting times? Is it about better use of the independent sector? And that's certainly one of the factors for us in the county, where the demand for private healthcare has gone up. I'm sure that's partly a consequence, Richard, of longer waiting times on the NHS. But how do we make sure that we're getting ring-fence capacity from the independent sector to make sure that we're able to optimise that? That's an absolutely key point. I think the second area is whether there's further private support, such as a Vanguard operating theatre that could be funded. We've got one coming onto the Alex site. Is there the possibility of further? We know that staffing for theatre staff is a national constraint, so that's obviously one of the constraints that we'll be dealing with. And I guess the other area is our own operating theatre productivity, and how do we make sure that we're optimising the use of our own assets. Beyond that, I think the major constraint for us is workforce, Richard, and I think that's part of the conversation that Paul is having with the region at the moment, because the substantive workforce is a challenge, but also we're seeing a real issue at the moment with staff having to self-isolate as a consequence of the NHS app saying they're in contact with somebody that's COVID positive. So we've got an immediate issue, but the fundamental problem is, have we got the workforce to be able to shorten waiting times in the right way? We don't have a coherent plan at this point in time to respond to that modelling information that was shared last month. So I think we should keep coming back to this. I know it's going to be a little bit like every month we're talking about this, but it is one of the major issues for us as a council and system that we have to tackle. Hence why, in the annual plan priorities, it's number 2. I know it's not a particularly helpful answer, Richard, but that's the challenge for us going forward, I think.
Okay. I mean, I agree that it's not obvious what the route out of this is at the moment, and we had a conversation at the ICS executive board on this. But if you think about the elements that we can control, the first and most obvious one is our own productivity, and you can see in some of the numbers here that we've got real issues about productivity in our operating theatres and our processes around all of that, and that has to be a significant part. I think GERF gives us some other clues as to what to do on all of that. The second issue is the use of the private sector, and there's already evidence that we're not using it very well, that we're not getting our processes right between ourselves and them to maximise the current utilisation, never mind thoughts about the increased utilisation. So that's another area I think that need to be pursued. The third one is what you might describe as the semi-private, which is the vanguard theatres bringing in extra staff in order to help us to do stuff, and there may be other opportunities around to make that happen. And then the final one is the kind of waiting list initiatives thing, about how we incentivise our own staff to do more work, and there's going to be some kind of combination of that. There may be other things that we need to do as well. They're not absolutely obvious to me what they are at the moment, but they're the kinds of areas that I think we need to tackle. And as part of that, the last time, I'm sorry I've been around too long now, but the last time we went for a big increase in elective activity to tackle waiting lists, we brought in a whole load of staff from overseas, doctors in particular, surgeons in particular, from overseas. So I don't know whether that's part of the calculations that we're going to use, or it's probably illegal now to do it or something. But anyway, so they're the areas, and there's going to have to be some kind of local and national action on all of that. But in the meantime, we need to get our act together as fast as we can, so we can move away from the idea of just adding on to these problems as we go along. Okay, so and just as an aside, I think it would be really helpful. Probably, I don't know whether the October meeting would be better for this, but to have a proper kind of analysis of what we're actually going to do in relation to all of this waiting stuff. Well, we also need to think about our winter plan as well. Now, whether we do the things together or not, I'll leave it to Matthew and the executive team to sort it out, because I'm genuinely worried that we don't have the capacity at the moment to deal with the problems that potentially could arise through a combination of a flu, a bad winter, and continuing increases of COVID. Matthew.
Yeah, thanks, Chair, and I completely agree. I think the challenge for us is how do we manage the urgent emergency care picture, which we don't know whether this demand is going to continue, whether this is a bulge in a kind of post-COVID, but we're going to really need to manage that alongside the restoration. We need to see it at a system level as well. So I think we would want to continue to develop the planning and the future analysis in the context of the system approach. So Chair, I think it's probably more likely that we'll have a system plan than necessarily a standalone Worcestershire Acute Hospitals plan. but we are going to need to be able to organise the metrics so that we can monitor and measure our elements of that, because that's the duty of this board as well. So it's going to be an element of system versus the components that our teams could do. And I think that we are stepping up our elective activity in the first few months in line with the plan. We've just got to continue to do that without breaking the bank, I think.
Okay, thanks Rob. Let's then move on to the committee assurance reports. I'll go through each one. So if there are things that people want, well, I don't think there are any in the reports that people want to bring to our attention, according to the notes that I have in front of me. So finance and performance, anything, Richard?
Well, we've discussed quite a few things. Maybe a few remarks. One is that we have agreed as a follow-up to the finance workshop, but in relation to this, the creation of the midterm financial plan and the underpinning operational plan, that we are going to review a plan for that plan in the next meeting, so that we can, over the next 6 months, actually follow this happens and leads to the desired result. Secondly, we spent quite a bit of time on digital and the DCR program, the PES program, and what's going on there. I think some good work from Vicky and the team, but we also requested that if we have budget overruns, they really think about how we fund these things and if they're absolutely necessary, and they give early warnings instead of late warnings. And I think that's it for as far as finance and performance.
Thanks, Richard. Quality governance?
Well, Julie wasn't there last time. I think the report is good, so people can read it. The only thing I maybe want to draw some attention to is medicine incidents. This was the only topic which I would have also raised in the IPR related to the quality section, and we have agreed that there's going to be proper analysis and a review in the next meeting.
Okay, thank you. Okay, let's then move on to, now we've got a series of staffing reports, I think, which will have been through committees, I guess, so I'm just conscious of the time. It's not because they're not important, but because we need to make sure that we're adding value as a whole board to all of this. So we don't need to go into spend a lot of time on that. We do say so. Staffing report, Paula.
Thanks, Chair. So, quite rightly, just a couple of points to note that we continue to try and maintain those safe staffing levels by moving staff around and using temporary bank and agency. And obviously, to Matthew's point around the fact of staff going into isolation and COVID, and working through those figures and how we managed to get out of and sort of review the rules around the app and then the test and trace model. So we're working through that. And the only other thing I wanted to raise was, obviously, staff are now feeling very anxious about having to go through another third wave, having gone through two previously. So the PA model that we've got is helping to do a bit of restorative supervision, and we're working through some of those themes that staff are bringing up and trying to support them. So we're still maintaining where we can. I know Justine will talk about sickness levels, because in this report, the staffing report, it talks about high sickness in maternity and related to stress. So I'll stop there for questions.
Okay. Okay, do you want to talk about midwifery?
Yeah, so Justine's on the line, so she'll talk to the maternity report.
Good morning, thanks Paula. Yeah, just some key headlines really. We have seen increased availability of midwifery staffing within this month, so that's due to reduced sickness, although as Paula pointed out it's still slightly higher than we'd want it to be, and the main theme is stress and anxiety. We've used agency staff and lots of new starters have come, which is why we've had that increased availability, so that's really good news. We've got good quality midwifery workforce data now, and I'd just like to thank Liz and Ben from Tina's team, because they have been amazing in getting finally some really good quality data to me. and that's helped us demonstrate that improvement. Outcome of this obviously is going to be reduced staffing incidents, reduced medication errors, and reduced delays in care, which is really good to see. There's no change in our planned next recruitment. The new starters that we expect in September, we're still expecting another 16. We're just keeping a really close eye on that because we don't want to delay any of those starts. That's really good news. We're going to stay at an assurance level of 4, and that's on the basis that we would like to be in a position of having no vacancies and bring those sickness levels back down to the, below the trust target. And I'm pleased to say that we had a further reduction in month, but you'll see that in the report next month. Paul has identified the current challenges around COVID, and we're obviously no different in maternity in terms of that challenge. So I'll pause there if anybody's got any questions.
Any questions? I mean, you raised the issue of stress and anxiety, I think. Do you think that our offer to staff is substantial enough and having any effect? Tina, do you want to respond to that? Or?
Yes, we do an automatic referral to occupational health for every case, any member of staff reporting stress, anxiety, depression, so that category. We haven't seen a significant increase in the trend across the trust. It's just pockets, so maternity being one of them. So it's about 5 above our normal run rate across the trust. Interestingly, the sickness absence has been more of the shorter term over the last couple of months rather than longer term conditions. So I think it's the fatigue that's coming through now.
Yeah. Okay, so we got the report for assurance. Yes, thank you. Maternity services continuity of care position.
Yes, so Justine will go through that paper and the CNST one as well.
Okay.
Thanks, Paula. As you say, Chair, this has already been through TME, so I'll keep it brief. I think we just need to remind ourselves why continuity is a national ambition, and those improved health outcomes are outlined in the paper, and that underpins our rationale for introducing continuity. As you know, we're at a current trust position of 28% against a national target of 35%. This target has now been superseded with a new target that we expect continuity to be our default position by 2023, and that means that we should have the majority of our women on this pathway by that time. So obviously, because of some of the feedback that we've had from our teams and the work that we still need to do, we need to look at our current cultural challenges, identify our successes, but also the challenges of the implementation of the initial strategy to roll out continuity. The paper identifies a few estate issues, and we obviously have got our workforce planning to develop the support roles, the MSWs, and we've outlined in the staffing paper our recruitment pipeline, which is positive. So moving forward, we will relaunch the continuity work stream and start to look at how we engage all of our stakeholders in a better way than we did initially at the outset of the rollout of continuity to ensure that we make that change. And we're going to do a further evaluation of where our current position and complete a business case to support the rollout to meet the national ambition for 2023. And I'll just pause there if anybody's got any questions.
Thanks. Any questions? Anita.
Thanks, Chair. Thanks, Justine. In terms of the continuity of care, and obviously you noted the report, is there given the other work that we're doing in maternity at the moment, is there a case for accelerating the movement model? The benefits are well defined. Actually running both systems in parallel is probably putting additional strain on us. Would there be something for saying actually we should go all out for this? And if not, what are the inhibitors? What are the things that are going to stop us doing that? Thanks.
So at the moment, I think that's a conversation that we've been having as a divisional team is, is it right to continue to do a kind of drip approach and roll out teams, 1 or 2 teams at a time, with the challenges that we've outlined in the paper and some of the feedback that we've had from the staff in the difficulty of making sure that there is no disparity between pathways when you run 2 at the same time. So yes is the answer, is something that is where we think we would be better going in 2022, but we've got a significant amount of work to do with our teams to get them alongside and work with us to be able to deliver that. So I think the pause has been really well received by the staff while we regather and re-engage and relaunch, and once we feel confident and we're getting that positive feedback from the staff that they're ready to go all out, then we can probably do that much more quickly, and the aim will be to get to that 2023 milestone.
Okay, thanks very much. Any other questions? Okay, thanks for that. Really useful heads up on the policy and what's happening in practice. Something that we as a board support, continuity of care, and we want to see it implemented, but we want to see it implemented in the most sensitive way to benefit both the mothers, the babies, and their midwives. Thank you. Let's then move on to Cnst Maternity.
Okay, so this again, this paper did go to TME because we were under the impression that we had to submit our board declaration by noon today. Fortunately, we've been given nationally an extra week due to some challenges with the document. So this has given us an opportunity really to finally to submit the final outstanding pieces of evidence to board. So within our evidence folder now, we have the additional sign-in sheets, audit around shift leader status, neonatal workforce, the continuity of care action plan, which we've just discussed now. We completed the smoking audit, and of course the staffing paper that I've just discussed will also be submitted as evidence as well. So we're asking for approval today that we're content with the evidence that's been submitted, and that we can prepare the declaration for sign-off and submission by the board by noon on the 22nd of July.
Okay, thanks. Do you want to add anything, Paula? Are we?
No, I don't need to add anything at all. Okay. It's very, very succinct about what we need to do.
Fine. Any questions? Okay, so we approve the submission. Yes. Thank you very much.
Thank you very
much.
Let's
move on then. Sorry, did somebody say something? No, I'm sorry. Okay, so let's move on to the next item, which is KP sepsis and PMRT. Oh my goodness, assurance report. And it's
So
Paula again. Paula and honestly, it's all.
Chair, I'll take that one. This has already been through QGC. It is coming here for assurance of the board. This is around making sure that from the West Midlands Neonatal Operational Delivery Board that it has come through board. This is about the neonatal early onset sepsis calculator and using this tool to identify the risk of early onset of sepsis that can be calculated on an infant. Can be calculated in an infant born greater than 34 weeks gestation, and it uses maternal risk factors along with infant clinical risk. So that is part of that, and then it's making sure that we've got enough staff to do the PMRTs, which is the perinatal mortality review tool, and we've both of those are absolutely assured at Worcester that we've got adequate resource clinicians to deliver that. And the KP sepsis tool is now live on Badgernet, and training commenced on the 21st of June. So this is just to say that it's gone through QGC and it's now coming through board, so I can assure the Neonatal Operational Delivery Board.
Fine, thank you very much. Any questions on that? Okay, we're happy with that for assurance.
Thank you.
Let's move on then to the mortality review update. Mike.
Yeah, so around the time I arrived, we commissioned Professor Buick to look at mortality across the trust because there were concerns about it. As you know, fortunately now we haven't that level of concern. But a number of recommendations came out of that, and this is to provide assurance to the board that those recommendations have been acted on. We are making progress. There are still some things to do as a consequence of refining what they originally sent through, but I think progress is good, and I think the board can be assured that we are moving forward on all the recommendations. So I'm happy to take any questions that people might have.
Thank you. What's the current position on mortality, Mike? What are we?
So we're just around 100 for both metrics. Interestingly, for the HSMR, we're below the 100 in hospital mortality, but have a slightly higher out of hospital mortality, which I think aligns to the recurring theme of the wrong patients arriving and us getting them home to die at home when they should never have been in.
Okay.
But we're at about 102 for HSMR and 101 point something for shimmy. And there are no highlighted areas at the moment of concern.
Okay. Good progress, but when you consider where we were a couple of years ago, anyway. But thanks for the work everyone's done on that. Matthew, and then Richard.
Yeah, thanks, Chair. I guess my obvious question: if we're at assurance level 5, what's the key that's going to get us to a 6 and a 7? What are the key things that need to happen next? Just bearing in mind you're handing those over to Christine as some of the first things to focus on.
So a couple of the little things are getting the app working in a way that communicates out the learning more effectively. So that was one of the key things that we've learned as we've started to use it. It works, but it doesn't quite push the learning out. So we're revising the app to deliver on that. We've now got sufficient medical examiners that we can now do all the reviews. What we've got to do is up the structured judgment review output from them as well. And we've got to get the bereavement areas sorted out at the Alex, which is a capital programme problem. So I think those are the key bits that will really make the next steps happen. And interesting, the mortality review group is being relabeled the Learning from Deaths group. So actually the focus is now not just doing it, but actually learning from it. And I think that's what will take us to the next step.
Thanks. Richard.
Yeah, not really a question. I mean, you've partially said it already, David. This was discussed in QGC, and we really also complimented Mike and the team with the work, because I think this is great progress over the last 2 years. And then we also discussed not just Matthew's question, but also how we're going to measure and follow this, and agreed it's going to be an integral part of the IPR, and think about maybe some specific KPIs to actually measure what Mike has been mentioning.
Excellent. Very good. Better never stops. Right, let's. So we take that for assurance. Thanks, Mike, for the work on all of that. Let's move on then to the Audit and Assurance Committee report. Anita.
Yes, I think the report speaks for itself. I have nothing to add unless anyone's got any questions. Thanks.
Very good. Thanks for that. And the Remuneration Committee, we made the arrangements for the secondment of the Interim Chief Finance Officer, who's here in front of us. And just as it wasn't on the report, but just to mention it, I think, was we did have a discussion about succession planning generally, and about bringing forward some really kind of important work around succession planning, not only to assure ourselves that we're building the talent pool in our own organisation, but to ensure that it fully reflects the workforce that we have, and that detailed work Matthew is taking forward. So thank you for that. Okay, we agree to that. Good. Any other business? Well, it just shows you what we can do. Okay, so are there any questions? Sorry, I've forgotten that. Any questions from anybody else about anything else while we're here? No. So the next thing we have is our private board meeting, which starts at 1 o'clock. So thank you very much for your attendance at this board meeting, and I'll see you at 1.